I want to talk very briefly about three sets of issues that I think are absolutely crucial as we see reform indeed in each of the 4 countries of the UK. First of all, the really crucial importance for people with diabetes of being able to rely on an integrated pathway of care constructed around their needs. And that has got some big challenges in terms of NHS reform, where we're going to see a range of commissioners rather than a single commissioner for services, with health and wellbeing boards, primary care trusts and the National Health Service Commissioning Board. So we need to make sure that services are commissioned in an integrated way between these organisations. We're working on the National Health Service Bill to do that. But we also need to make sure that commissioning isn't just GP commissioning consortia, but is an integrated commissioning process involving not just input from primary care, but also from specialist care, and indeed a multidisciplinary process involving a whole range of professionals alongside strong involvement from patients. And we also need to see integration between providers. If we're going to see any willing provider, though I noticed that Andrew Langsley now calls it any willing and competent provider, we would like to see it as any willing and competent provider who's going to promise to work in collaboration and provide integrated services with all the other providers, and indeed undertake support for teaching, research and audit. How's that for a catchy little title? The second issue I want to just focus on, that's at the top of many people's minds, is the economic squeeze. And we are seeing pressures that mean that care pathways are being altered, sometimes positively redesigned, sometimes altered by default. And we need to make sure that in the search for the most cost-effective patterns of care, we don't downgrade the value of specialist care. And Diabetes UK will be campaigning to make sure that doesn't happen. But there are things, I think, that we can see before us that are of benefit not only in quality of care but also in economic value, and particularly tackling those complications of diabetes that with good care in the early stages could in fact be staved off or avoided. So we really do want to look at how investment in the earlier part of the care pathway and the prevention of complications can make sure that the huge sums of money that are invested in diabetes care are invested in the things that are good for patients in terms of primary and secondary prevention and early diagnosis and intervention, rather than mopping up the pieces at the back end of their care. Later on this week, there will be data launched about the average length of stay for inpatients with diabetes in care generally. Because it's embargoed to later on the week, I would have to kill you all if I told you what the outcome was. But I think we'll all be staggered at the increase that's now about to be announced in the length of stay above average of people with diabetes compared with those without. And that's a pretty wasteful thing. So we need to make sure that patients in hospitals, in whatever specialty they are getting proper input for their diabetes. The third area that I want to focus on is standards of care. We've got standards coming out our ears. We're going to have launched this week the new NICE quality standards. Diabetes UK has been working on some standards from the patient perspective, and of course in Scotland, Wales and Northern Ireland there are standards for diabetes care adopted nationally. So we're not short of ways of knowing what it is that patients should be getting, but we are clear that in a range of places they don't always get everything that they should. One of the pieces of work that Diabetes UK is going to launch during the summer is our new Standards Watch programme, using published data from the National Diabetes Information Set and from clinical audit, joined with up-to-date intelligence from our network of volunteers, from our collaborating professionals and from our own staff on the ground. We believe that we can track the quality and standards of diabetes care in real time, and make sure that not only do commissioners understand where changes need to happen, but also that patients locally know what standards they should receive, what standards they are receiving, and are able to interact with their commissioners, with their providers and with their healthcare professionals to seek the sort of care that they should all have an entitlement to. We also want to use that information to work locally with professionals and indeed with commissioners and providers as they emerge in the new structures, and to advocate for improved standards where there are issues that are clearly countrywide. And it's likely that in the light of some of the announcements that you're going to hear about diabetic specialist nurses and the challenge for them as a result of the squeeze, that we will make that our first national report.